Hello, this is Nursing School. My name is Patrick. Today, we are going to learn about diabetes ketoacidosis DKA. Remember to subscribe, like and share, comment and make free exercise on nursescatalyst.com. Diabetic ketoacidosis. DKA is caused by an absence or markedly inadequate amount of insulin. This results in disorders in the metabolism of carbohydrates, protein, and fat. The three main clinical features of DKA are 1. Hyperglycemia, due to decreased use of glucose by the cells and increased production of glucose by the liver. 2. Dehydration and electrolyte loss, resulting from polyuria, with a loss of up to 6.5 L of water and up to 400 to 500 MEq each of sodium, potassium, and chloride over 24 hours, and 3. Acidosis, due to an excess breakdown of fat to fatty acids and production of ketone bodies, which are also acids. Three main causes of DKA are decreased or missed dose of insulin, illness or infection, and initial manifestation of undiagnosed or untreated diabetes. Clinical manifestations: polyuria and polydipsia, increased thirst, blurred vision, weakness, and headache. Orthostatic hypertension in patients with volume depletion, frank hypertension with weak, rapid pulse. Gastrointestinal symptoms, such as anorexia, nausea and vomiting, and abdominal pain, may be severe. Acetone breath, fruity odor. Small respirations, hyperventilation with very deep, but not labored, respirations. Mental status varies widely from patient to patient, alert to lethargic or comatose. Assessment and diagnostic findings. Blood glucose level, 300 to 800 mg per deciliter, may be lower or higher. Low serum bicarbonate level, 0 to 15 MEq tel. Low pH, 6.8 to 7.3. Low PaCO2, 10 to 30 mm of mercury. Sodium and potassium levels may be low, normal, or high depending on amount of water loss, dehydration. Elevated creatinine, blood urea nitrogen, BUN, and hematocrit values may be seen with dehydration. Medical management. In addition to treating hyperglycemia, management of DKA is aimed at correcting dehydration, electrolyte loss, and acidosis. Rehydration patients may need as much as 6 to 10 L of fluid. 0.9% normal saline is administered at a high rate of 0.5 to 1 L/H for 2 to 3 hours to replace fluid loss caused by polyuria, hyperventilation, diarrhea, and vomiting. Hypotonic, 0.5%. NS solution may be used for hypertension or hyponatremia and for those at risk for heart failure. This is the fluid of choice. 200 to 500 milliliters per hour for several additional hours after the first few hours, provided that blood pressure is stable and sodium level is not low. When the blood glucose level reaches 300 mg per deciliter, 16.6 millimoles per liter, or less, the D4 solution may be changed to dextrose 5% in water, D5W, to prevent a precipitous decline in the blood glucose level. Plasma expanders may be used to correct severe hypertension that does not respond to fluid treatment. Restoring electrolytes. Potassium is the main electrolyte of concern in treating DKA. Cautious but timely replacement of potassium is vital for avoiding severe cardiac dysrhythmias that occur with hypokalemia. Reversing acidosis. Acidosis of DKA is reversed with insulin, which inhibits the breakdown of fat. Insulin, only regular insulin, is infused at a slow, continuous rate, exaomly, 5 units per hour. For fluid solutions with higher concentrations of glucose, such as NS solution, Example, D5-NS, D5.45-NS, are administered when blood glucose levels reach 250 to 300 mg per deciliter, 13.8 to 16.6 millimoles per liter, to avoid too rapid a drop in the blood glucose level. For insulin must be infused continuously until subcutaneous administration of insulin can be resumed. However, for insulin must be continued until the serum bicarbonate level improves and patient can eat. You can test yourself on nursescatalyst.com. Remember to subscribe, like and share, and comment. Your follow is our priority.